It's recording, James.
Thank you, sir. Today's agenda will start with the VEST update, vaccination unit update, other PH ops, DCLS update, the modeling update, and questions and updates from local health districts. Although I believe that the VEST update has been skipped for today. Is that correct, Donald?
Yes, that's correct.
All right, we're going to go ahead and move on. First up is going to be the vaccination update with Marshall Vogt. Marshall, if you can please take the call.
Good morning, everybody. If we could go to the next slide, I'll go ahead and cover the agenda that we have today. I have some general updates about vaccine availability in terms of new vaccines coming to market, and then quite a bit of information about the vaccine campaign, and then a few things to touch on with VAMS and Prepmod. So if we go to the next slide, I'll start off with updates on vaccines. Very happy to announce that Johnson & Johnson, you may also see them as Janssen. Janssen is simply the pharmaceutical arm of Johnson & Johnson. They submitted their emergency use authorization, or EUA, to the Food and Drug Administration for their one-dose COVID-19 vaccine. There is a VRBPAC meeting, which is the Vaccine and Related Biological Products Advisory Committee, scheduled for February 26th. This will be the next step to get full emergency use authorization approval for the vaccine. It then, of course, needs to go over to the Advisory Committee for Immunization Practices for their formal recommendations for usage, and that would allow probably around early March the ability for us to start using the Johnson & Johnson vaccine in the United States. Of course, what that means for Virginia, allocations, the fact that the vaccine is a little bit less effective, there's a lot that is still up in the air, but we are making some progress, and that's very exciting. In addition, I'm happy to announce that, and you all have probably realized this, you can get 6 doses out of each vial of Pfizer vaccine. So now when we're doing ordering and allocations and distribution for Pfizer, you're still going to get 195 vials per tray, but you're going to be able to get 1,170 instead of 975 doses out of those vials. So that's going to affect how you do your inventory and how we do our allocation and those sorts of things. And I do see a question there about the ancillary kits. The ancillary kits have been scaled up as well, or at least that's what we've been told. And remember, there are ancillary supplies available from pharmacy services as well. If we go to the next slide, we'll start talking a little bit about updates to the vaccine campaign here in Virginia. First, touching on eligibility and access, remember the ultimate goal is vaccines in arms, and you all have been working hard to accomplish that. I know there are many clinics running today, even as I look outside the window and see snow and ice on the ground. So thank you again for all of the hard work that you're doing. Please continue to reach out to those in your district and remind them that we are in phase 1B, that phase is very large, and we're working through that phase as much as possible, but we're also having to work through that phase 1B in a stepwise progression through that 1B list of essential workers, even as we may continue to be finishing up some phase 1A vaccinations. Remember, the preference is for a vaccine recipient to receive the vaccine in the local health district where they live or where they work, depending on their phase 1B priority group, but there's no residency requirement. There's also no requirement to prove underlying health conditions. And please remember that some of these categories have some finesse to them, shall we say, some nuances, including the fact that, for instance, private school teachers are technically K-12 teachers and staff. Childcare workers are the same. Primary caregivers for those with chronic medical conditions or intellectual or developmental disabilities would be considered 1A healthcare providers. So there are some nuances. Please reach out to us with questions, and we can help work through those as you're working through phase 1B. On the next slide, we'll give some additional updates here on our vaccine campaign, and particularly related to our implementation of a statewide enhanced COVID Information Center. So we're calling it the VCIC. And this is basically an enhanced call center that will have hundreds of agents and be much more flexible and scalable to hopefully take some of the pressure off of local health districts. It actually went into soft launch this week. So the 877-ASK-VDH3 number was routed to this new call center that is again expanded. It will have a full launch next week with a formal announcement from the governor's office. And then again, we'll be able to scale this up as needed. Right now, It is basically replacing the 877 Ask VDH3 line in terms of answering frequently asked questions. But eventually, and starting next week with the rollout of this pre-registration tool that is going to be centralized, the call center is going to be able to help people pre-register for the vaccine and actually assist with making vaccine appointments in Prepmod once people are eligible. So more to come on this, but the idea is that this call center is going to transform from just answering FAQs to helping people actually complete pre-registrations and possibly some appointment registrations as well. We're working with local health districts to make sure that if you have local health district call centers, those may still remain operational, and how we're going to work back and forth between those to make sure that when people need to be referred to the local health departments, they're getting to the local health departments. More information is to come on that. I think we've talked with a lot of you already. The call center planning team is very receptive and wants to hear about these situations so we can work with you to make sure that we're getting people routed the way they need to be routed and also taking some of the strain off of you all at the local health districts. One other way that we're doing this is by developing a standardized web-based pre-registration tool. That is almost complete, and we are very excited that that's going to be rolling out. It is a standardized public-facing data collection instrument that's really going to replace the fragmented pre-registration tools that have been deployed across the Commonwealth. It's going to integrate all of the information that you have already collected, so no one is going to lose their place in line or lose their data, and it's going to empower you at the district level to be able to see who in your district has pre-registered and what categories they fit into. You're going to be able to slice and dice that data. There's been a lot of demonstrations going on. There's one going on right now with Carlos, who's our Chief Data Officer, and he is working along with a team with Jesse Silver and others to really build this tool out and make it useful and meaningful for you so that you're able to download your data after you've sliced and diced it and come up with a list of your next people that you want to tackle to provide vaccine to. This will also eventually allow you to download this data and then upload it into Prepmod to generate appointments. We hope that that functionality will be online next week or the week after, and I'll talk a little bit more about that later in the call here. What's very important as we make this transition this weekend is that we have to bring down those pre-registration systems that are in existence across the Commonwealth right now in order to combine everything and do a final data cleaning and deduplication. We're actually running the data against this, against other databases to try to fill in missing information, but we need the weekend to do that. So please reference the email that Dr. Avula sent yesterday. It went out to local health directors and some others that are involved with the pre-registration conversion. It went out at 4:54 yesterday, and it talks about the timeline for all of that and are asked for you for transforming your websites, if applicable, as well as taking down the pre-registration tools to allow that data consolidation to happen. As we move on to the next slide, some updates for the federal retail pharmacy program. Remember, this is separate from the Partnership for Long-Term Care Facilities. As you're probably aware, unless you've been living under a rock, there's been a lot of media attention on this in Virginia. CVS has begun registering Virginians age 65 and older who are part of that Phase 1B eligibility group that CVS is going to be working with to provide vaccine. And right now, that's going to be those 65 and older. We really wanted to work with CVS to try to put together a pre-registration tool that would link with our pre-registration data so that we weren't in a position where we had people kind of jumping the line. Unfortunately, that was not possible, and CVS stated that they had technological limitations on their side, so they started opening up those appointments earlier this week. Those first vaccines are actually going to be administered today, and then they're going to continue working through it in kind of an iterative process as they receive more vaccine. This is a separate allocation from the federal government, and we hope that this allocation will expand to other pharmacies in this federal retail pharmacy program as time goes on. Again, this is not ideal because we wanted them to use our pre-registration data, but we also do realize it's another avenue to get vaccine in arms, which is very, very critical. So we are excited that this program is up and running, and we're hopeful that other pharmacies are also going to be engaging in this program as time goes on and more vaccine is available. Next slide, please. A reminder, as you're running your vaccine clinics in the districts or as you're redistributing to providers, please make sure that they're reporting vaccine wastage, including retroactive reporting of vaccine wastage using our survey. And that survey is available on the healthcare professionals page on the COVID-19 website, the external VDH website. It's really important that we're able to report this wastage back in VTRAX to the federal government because that is part of our reporting requirements from the federal government. So it is very important that you report that wastage, and please encourage your providers to report that wastage as well. Next slide, please. A reminder for data reporting and reconciliation. You all have probably seen this dashboard. It's called COVATS. It's a system that lets you know where vaccine has been allocated and look at your administration numbers that we're pulling from VIS to make sure that everything is matching up. We've received a lot of requests for this information from the public, and we know that we have to be responsive because some of these requests have invoked the Freedom of Information Act. As such, we are going to be releasing, the planned release is next Tuesday, February 16th, a public level dashboard that will have kind of very basic organization level details in terms of the organization, the net doses received, and the doses administered. So that dashboard, we just want to make you aware, will be going live to share that data. We understand there are some concerns with that, and we're trying to work through those concerns, but also balance that with the need to make that data public by the public records request that we've received. Another reminder around redistribution, survey usage, the shipper, the person who is actually doing the redistribution of the vaccine, should be completing that survey in a timely manner to indicate that redistribution is occurring. We need to know that as well. That fits into that allocation dashboard to know about distribution as well as redistribution. Next slide, please. And if we'll go to the next slide, just a few Prepmod updates from the Prepmod team. These were presented on the 10th on our weekly technical assistance call with the local health districts. You can see now that we're inching closer and closer to our target date of February 28th, where all health districts will be loaded into Prepmod and running clinics in Prepmod. You can see that it's a little hard to read here, but pilot, wave 1 and wave 2 are all now onboarding into Prepmod. Training has more or less concluded, but we are continuing to do one-on-one training as needed. So if we go to the next slide, there are some training dates that have been scheduled that you can see here on the screen. This slide real quickly just shows you kind of where we are. We can move past that in the interest of time to the next slide, which I believe has the training dates on it. Just for your situational awareness, of course, there are office hours and one-on-one training sessions that will be conducted. And you can see there's some office hours happening. They happen today at 9 o'clock, but you can see scheduled for next week 4 different rounds of office hours, as well as one-on-one sessions. Please email Nitin, Dana, and Sue to schedule training sessions for next week. If we go to the next slide, some final updates on Prepmod. Coming down the pike, we are very excited that there are going to be some updates made to Prepmod, including that individual survey link that cannot be shared. That went into staging today, and we're hoping that that will go into production next week or the week after. There's also going to be the ability to do that bulk upload that we've been talking about, as well as when people are working for or working on registering for an appointment in the Prepmod system, it's going to kind of hold their place in line. So once they find that appointment, they can complete that registration process, and they're not going to have to worry about getting to the end of that and other people kind of swooping in and taking that appointment time. So some additional upgrades are coming to Prepmod. We know that they have been very much in demand, and we've been pushing the Prepmod folks as much as possible to get these updates to us. They have had some technical issues that they've largely worked through, and we're hoping that if they're in QA over the weekend, that means they can be in production by sometime in the middle to late next week. I think there's one final slide here on Prepmod, just to show you some friendly reminders. When you finish your clinics, please remember to click the Save and Submit button, because that is what ensures that the actual data from the vaccine clinic, the dose administration data, is getting transferred over to VIS. And remember, there are best practices for scheduling a second dose clinic, including naming a venue or location and including second dose clinic. and then scheduling patients for their second doses before they leave that first dose clinic. We know there were some issues yesterday doing that in Prepmod, but those clinics, that issue has been fixed, and Prepmod is going to be working to make sure that those individuals are put into the right clinics for their second dose. Remember that when adding organizations and providers, please validate the VIS org code and the Prepmod, or with the Prepmod team rather. We want to make sure that that data is getting over correctly from Prepmod into VIS. And then remember, if you have clinics that have multiple lot numbers of vaccine, make sure that correct lot number is selected. And if you have issues with an incorrect lot number that's been entered for a vaccine recipient, again, please notify Nitin, Dana, or Sue, and they can work to get that taken care of. If we go to the next slide, I believe that concludes all of my Prepmod updates. Just a couple reminders and updates for VANS. The VANS help desk is now routing all calls from users that contact the CDC to the Virginia COVID Information Center. So this is our new expanded call center. This is important because it is the 877 Ask VDH3 number, but it's an expanded service, and they have FAQs that they can answer. A lot of those calls, hopefully they can answer at the call center, but some of them may need to be referred to local health districts. So that would be things like, I need to change my appointment, or an employer that needs to contact you because they need help in VANS. So please ensure that your local health district staff are routing these calls to your VANS leads at the health districts if they're health district specific. If they get routed to, say, our main immunization line, we're not able to help people out. So it's very important that the help desk individuals at our call center are dealing with the calls as best they can, but any being referred to your local health districts that might be local health district specific, please remember that there may be a need for you all to help handle those on the ground rather than referring them to our immunization main line. And if we go to the next slide, I think that is everything I had. Again, a huge thank you to all of you, especially working in the snow and the ice. I know there's a lot of ice forecasts for areas in the state, so please be safe, and hopefully you get a little bit of downtime in the midst of all of this, in addition to President's Day. But for those of you working over the weekend and for the holiday, thank you so much. We do appreciate all of your dedication and continued effort. With that, I'll turn it back to you, James, and tackle questions in the chat. Thanks, everyone.
Thank you, Marshall. Next up is the other PH ops, which includes in health information, investigation, surveillance, containment, and informatics and information systems with Laura Young. Laura, if you're on the call, please take the call from us.
Thanks, James. Can you hear me?
We can. Please go ahead.
All right. Okay, you can go ahead to the next slide, please. Thank you. So I'm going to give some updates for a variety of groups from ops. So to start with health information, the team updated the vaccination FAQs yesterday, and the updates involved adding new questions about clergy members and prioritization phases, what protected health information is reported to VDH and CDC, whether proof of receiving the first shot is required for getting the second shot. Other FAQs are updated, including information about the federal retail pharmacy program and CVS in Virginia, and the VDH COVID vaccine wastage form. Next week, we have another update planned, directing people to the VDH site for pre-registration, and also adding in any long-term care facility updates, as well as new language about quarantine and vaccination. The general FAQs were also updated this week on Wednesday with new questions added about double masking, what people should do now that there are COVID-19 variants spreading, how to see the comparison of vaccine doses administered to vaccine doses received in a particular city or county, and questions about whether any animals in Virginia have been infected with SARS-CoV-2. Other updates involve the CDC mask order for travelers and in transportation hubs, vaccination and travel, and the DOLE final permanent standard. Next slide, please. The health information team also worked with DCLS and the containment team this week to revise the COVID-19 guidelines in the DCM. These were posted yesterday evening, so thanks to everyone for work and review of those documents. First, there is a new section on emerging SARS-CoV-2 variants where we provide information on when whole genome sequencing at DCLS should be considered, emphasize that confirmed cases should be prioritized for case investigation and subsequent contact tracing, and describe how central office will report these cases on to CDC. We also added a new section on investigating vaccine breakthrough cases. CDC defines the vaccine breakthrough case as one where a U.S. resident has SARS-CoV-2 RNA or antigen detected on a respiratory specimen that is collected 14 or more days after completing the primary series of an FDA-authorized COVID-19 vaccine. So if a local health department identifies a case that fits this definition, they should report it on to their regional FE or to central office staff. And then central office staff will work in collaboration with the local health department to determine if there is any residual specimen for further testing. This should still go through VEDS, so local health department should also report through VEDS, and then VEDS information will be submitted to CDC. Central office staff will also report the case to CDC through their REDCap database. The last major update to the guidelines involved adding a brief section about COVID-19 vaccines. Next slide, please. On February 10th, CDC updated their interim clinical considerations for use of mRNA COVID-19 vaccines to include quarantine recommendations for vaccinated persons. So this is something we'd all been looking for and waiting on, but there's still really limited information on how much vaccines might reduce transmission, how long protection lasts, and the efficacy of available vaccines against emerging variants. So at this time, it's still recommended that vaccinated persons continue to follow current guidance to protect themselves and others, so wearing masks, maintaining distance, performing hand hygiene, and avoiding crowds. However, in this updated language, vaccinated persons with an exposure to someone with suspected or confirmed COVID-19 are not required to quarantine if they meet all of the following criteria. So they have to be fully vaccinated, meaning at least 2 weeks have passed since receipt of the second dose in a 2-dose series, or at least 2 weeks have passed since receipt of 1 dose of a single-dose vaccine. They also have to be within 3 months following receipt of the last dose in the series, and they must have remained asymptomatic since the current COVID-19 exposure. So it's a pretty limited group of people who will fall into this category, but that is what we have for now. Fully vaccinated persons who are not required to quarantine, however, should still monitor for symptoms of COVID-19 for 14 days following an exposure. These quarantine recommendations for vaccinated persons, including the criteria for timing since receipt of the last dose, will be updated when more data become available and additional COVID-19 vaccines are authorized. There is one notable exception, and that is that vaccinated inpatients and residents in healthcare settings, so including nursing homes and long-term care facilities, should continue to quarantine following exposure to someone with COVID-19, given the increased risk and the nature of the setting. VDH is adopting this guidance, and we've already updated some of our public-facing materials, and we'll be working over the next week to update our websites and additional documents. Next slide, please. We also wanted you to be aware that on Wednesday, CDC released updated guidance about masks. CDC now recommends that for better fit and extra protection, there's an option to wear 2 masks. This is something that we've seen all over the media, so it is finally coming out from CDC as well. So a disposable mask can be worn underneath with a cloth mask on top, or a cloth mask can be combined with a fitter or a brace. CDC also provided recommendations and instructions for knotting and tucking 3-ply masks for better fit and protection. Better fit and additional protection might be needed and is recommended in certain situations, such as when using public transportation, especially when individuals are unable to stay 6 feet away from others, when caring for someone who is sick with COVID-19, when working at a public-facing job where there are many interactions with others, or if you are at increased risk for severe illness. CDC also added additional information on KN95 masks, enforcing that these should meet requirements similar to those set by NIOSH, that they should not be worn by people with facial hair, and to be aware of counterfeit KN95 products. They also do mention that KN95 should not be used with a second mask. They should only be worn alone. CDC continues to recommend reserving N95 respirators for healthcare personnel. So our public-facing webpage on masks has been updated to align with these CDC recommendations, and Sudal is working on some social media shareables and posts to capture this new guidance, which will be available as soon as possible on the social media hub. Next slide, please. VDH continues to receive reports of variants of concern affecting Virginia residents. As of February 10th, 5 cases of SARS-CoV-2 B117 variant have been identified in Virginia, with 4 occurring in the northern region and 1 in the northwest region. 1 B1351 variant has been reported in the eastern region, and a press release is planned for later today announcing additional cases. Next slide, please. We do ask that you continue to prioritize investigation of cases that are identified as a variant of concern. If the patient was not initially interviewed, it's important, and we ask that you please go back and conduct an interview as soon as possible and ensure that VEDS is updated with key information. It's also important to prioritize the identification of close contacts, especially those who may have been ill prior to the case patient, and enroll those individuals in monitoring. Please prioritize specimen collection on these individuals and request whole genome sequencing at DCLS for those who are positive. VDH is coordinating with CDC to stand up a few pop-up testing sites in the areas of interest to attempt to gauge if there is more transmission of variants. All positive specimens will have whole genome sequencing performed at either DCLS or a contracted lab, and lab results will be shared with the local health department as soon as results are available. A communication plan about the importance of public health measures is being developed around the topic of variants. Next slide, please. So several updates from infection prevention and control. Next week, we welcome Wendy Ferris as an infection preventionist for the Central Region. Recruitment is ongoing for regional IPs for the Northern, Northwest, and Eastern regions. A long-term care facility clinician letter was distributed and posted to the Long-Term Care Task Force website on February 9th. This was an update to the September 9th clinician letter for long-term care facilities. This update includes reminders on available infection prevention and control guidance, aerosol generating procedures, COVID-19 testing, point of care test reporting via NHSN versus the VDH portal, influenza testing, and Project First Line. The letter also included an update on COVID-19 vaccination in long-term care facilities and guidance following COVID-19 vaccination. This clinician letter did not go through the Commissioner's office, but was instead sent to the Long-Term Care Task Force members and shared through the Long-Term Care Association. Next slide, please. As a reminder, REDCap form was created to manage requests for remote infection control, infection prevention and control assessments, or tele-ICARs, with long-term care facilities. This link has been included in the notification emails sent to districts when a nursing home is identified as a hotspot, meaning they have 10 or more new resident cases reported to NHSN in a reporting week. The number of nursing home hotspots has consistently decreased over the past few weeks, which is good news. So the team is opening up tele-ICAR requests for any long-term care facility where the district thinks a consultation with the HAI team would be beneficial. The HAI team is prioritizing these requests based on facility type, outbreak status, if they've had a recent on-site visit, and team availability. But facilities can now directly submit a request for assistance, or local health departments can submit a request on behalf of the facility. The link is included on the slide and can be shared with facilities in your district. Next slide, please. This slide illustrates the number of long-term care facility outbreaks reported each week since the start of the pandemic by the 5 health planning regions. Data are from VOS and are as of February 6th. What we have seen is that as transmission of COVID-19 increases in the community, the number of long-term care facility outbreaks increases as well. As you can see, long-term care facility outbreaks in regions have shifted over time. In the past 30 days, the highest proportion of reported COVID-19 outbreaks in long-term care facilities occurred in the central region with 28%, followed by the southwest region in the darker blue with 22%, Northwest with 19%, Northern with 16%, and Eastern with 14%. Next slide, please. This slide illustrates the number of new resident cases, seen in red, and the number of resident deaths, shown in orange or yellow, reported each week from Virginia nursing homes. Nursing homes have been reporting data weekly to NHSN. The number of new reported resident cases have been steadily decreasing the past few weeks, with the week ending January 24th having the lowest weekly count since the end of November, when the count was 492. The number of reported resident deaths decreased slightly from the previous week, so from 187 to 160. Next slide, please. We have a few updates to share on contact tracing. At this time, local health departments are strongly encouraged to move away from case investigation and contact tracing prioritization and evaluate the resources that would be needed to maximize case patient follow-up and contact elicitation and contact follow-up. Case numbers are decreasing currently, and with the introduction of the new variants, this is a critical point in our response to re-engage extensive and comprehensive containment efforts. Surge team assistance is available and can be requested using the REDCap request form. And there is an opportunity to expand teams if needed to support the caseload, so please submit staffing requests to SBS. Additionally, the contact tracing team can help provide general process and operational support and provide helpful shared resources as needed. Please send any specific questions or needs to our shared inbox so that we can respond to help meet your needs. And that's COVID containment at vdh.virginia.gov. Next slide, please. Now we have a couple updates from surveillance. The enhanced surveillance team in DSI will be conducting surveillance using Essence for multi-system inflammatory syndrome in children, so MIS-C, using the new official ICD-10 codes that became effective on January 1. A health district will be notified to follow up with the hospital when an emergency department visit found in Essence is hospitalized and diagnosed using either of the two new official ICD-10 codes, and when there is no existing MIS-C investigation in beds for the patient, and if there is a positive SARS-CoV-2 test result, PCR antigen or serology in beds within the 4 weeks prior to the patient's ED visit. The team will update the COVID-19 dashboard within Essence and the new MIS-C definition being used by central office. Next slide, please. Moving on to our outbreak surveillance, there have been over 2,400 confirmed outbreaks created in VOS. 37% are in long-term care facilities, while 23% are in businesses and workplaces, with 15% in educational settings. Next slide, please. A total of 56 outbreaks were reported in VOS last week with a confirmed etiologic agent of SARS-CoV-2. Last week, the most outbreaks were reported in the central region, with 20 outbreaks reported, 14 in northern, 9 in the northwest, 7 in the southwest, and 6 in the eastern. Next slide, please. Finally, this is my last slide. We have some updates from the informatics team. The VED servers were upgraded Sunday night, so this was the 7th, and we're pleased to see improvements in system performance due to the upgrade. Navigation should be faster, so we hope that people are having an improved experience. The team does plan to update the auto closure scripts that run on Sunday mornings from closing open COVID-19 investigations that are more than 21 days old to closing those that are more than 14 days old. This shorter time frame will ensure that the open investigations queue stays lean and loads more quickly. A reminder that COVID-19 vaccination event is available for data entry. The team is also in discussions with program leads and CDC developers about how best to capture COVID variant information in the investigation. For Sarah Alert, the release plan for February 23rd should feature the null race ethnicity options that the team has been requesting, and the release on March 9th should have vaccination fields as well. For our contact tracing community, we recommend attending the office hours this coming Wednesday, the 17th at 10 a.m. We'll be announcing efficiencies to the out-of-state transfer protocol, and we will also touch on a survey for our community to be sent out in the coming week or two. Thanks for all of your work and all of your time. That's all I have from the ops group, and I think people are handling questions in the chat, and I will look there for additional questions. Thank you.
Thank you, Laura. Next up, we'll have the DCLS update with Marilyn Freeman or Colleen Courtney. Can one of you please take the call?
This is Colleen. Can you hear me?
We can. Please go ahead.
All right. So our DCLS week at a glance, we performed over 3,500. You can see 564 COVID-19 tests. Again, we had 0 serology submissions for our total IgM IgG. We shipped 1,580 kits and also distributed 114,840 media tubes, as well as 130,000 swabs. Our capacity remains to be at 1,500, although we are bringing on several new instruments to increase capacity, and we have additional capacity through our one lab. So far in 2021, we've performed over 22,000 tests, and in total sample sequence is over 1,800. For our 3 updates, we have 3 additional residents. It was already touched on in the call, I think included in those 6. We had found 3 of the additional B117 variants here at DCLS, 2 in the northern region and 1 in the northwest. We are prioritizing long-term care facilities for sequencing testing. So if you could please indicate on the sample submission form under the facility name, submitter, or in the comments section that it is a long-term care facility or resident facility, we will prioritize sequencing for those submissions. We have begun piloting for the DCLS Connect portal use with non-VDH submitters using a 2-factor authentication. So that is underway and so far going well. Next slide, please. This is just a look from the previous week, looking Thursday to Wednesday at the samples that we received at DCLS. You can see we're receiving around 500, so not hitting our capacity, much less sample submissions as compared to previous weeks or months. Next slide. Oh, not sure. Can you try advancing and seeing maybe? Yes, okay. This is a slide from Logan Fink. Can you keep advancing? I just had the whole slide pop up. If there's maybe one more. There you go, thank you. So those of you who were able to attend Logan Fink, he's one of our bioinformaticians, gave a lunch and learn for VDH about our sequencing workflow, but just because everyone is talking about sequencing and the variant, I thought it'd be timely to kind of go through what the workflow is here at DCLS and kind of demystify how we do this. So most people are well aware now and very familiar with the PCR process. And I just have that little, depiction of a PCR curve there at the top. But once we get a PCR positive, we can move on to sequencing depending on the quality of the RNA that was extracted. So unfortunately, not all positives are we able to glean great sequencing data. There does seem to be a correlation with the amount of viral RNA present. So that viral RNA that has been extracted is sequenced. We at DCLS primarily use the Illumina platform for our sequencing base. This run usually takes about 12 hours. And then once we get the reads from the sequencer, those are submitted to our bioinformatics team, where they perform genomic or genome cluster analysis. And then next slide. Yeah, I think we might have to advance some of the arrows again on this one. Sorry about that. Yeah, oh, one back. There you go. And so what does that mean? What do we do to perform genomic cluster analysis? So actually, our lab and our bioinformaticians worked in collaboration with the Wisconsin Public Health Lab. They're another very large public health lab in the nation, and developed a tool called Mrna. This is available for free online, and it can be downloaded through GitHub. It is a command line based platform, so it doesn't have a great user interface. It is managed in a command line, but this product is called Mrna, and it does all the quality analysis and cleaning up of reads as far as what's coming off of the instrument. Then once we have that cleanup file, we are able to submit to what's called Pangolin. This is an international software that was developed in Scotland. And this is really where all those names, the B117s and B135s, are coming from. This is also, I believe, a free software that people can use and that we are using here at DCLS. So when we call these variants, that's where that kind of all that data and that all the updates that are coming through internationally are going into this Pangolin database. Next slide. I wanted to share this with you. This is also from our bioinformatician, Logan Fink. It's hard to see kind of the dates, but starting when DCLS began performing sequencing for SARS-CoV-2 in March of 2020, kind of updating until now. And I'm not expecting anybody to be familiar with all of these clades. They change all of the time, but you can see the shift that there has been a sequence variation and shift in sequence of the circulating strains in Virginia. And now you can see we kind of have this primary 20G, and this is all provided via a product called NextClade. So there are both clades and lineages, which makes it even more fun and confusing. But I guess the takeaway here is we have seen this shift in the strains that are circulating here in our state. Next slide. As usual, we have our contact information for sample submission. That's Terry Harper. Any IT or DCLS Connect portal questions to our Director of Laboratory Operations, Emily Hopkins. And as far as sample submission and prioritization, that's Dr. Latoya Griffin-Thomas. And then I have both the contact information for the lab and myself and Dr. Bibbs Freeman. So if anybody has questions, I will take them in the chat. Thank you.
Thank you for the update. Next up will be the modeling update with Chelsea Kanan. Chelsea, are you on the call?
Yes, I am. Can you hear me okay?
We can. Please go ahead.
Okay, great. Can move on to the next slide. Great. So I will be summarizing the updates to the UVA model this week. Again, it was done by the UVA Biocomplexity Institute, and some of the additional analyses shown in these slides were provided by RAND. Next slide. So starting with an overview of national trends, there are currently no states that are showing a surge trajectory. All of the states are in either the blue or yellow categories, showing that we do not see any surges happening anywhere in the country. Next slide. And looking a little bit closer to home, both Virginia and all of the neighboring states are currently experiencing very high caseloads, which is classified here as more than 20 cases per 100,000 people. Although all of the states except for North Carolina have shown a decrease. Compared to last week, Virginia has experienced a 12% decline, and declines in all of our neighboring states are similar, with a fairly large decline in West Virginia, and then a slight uptick in North Carolina. And looking at Virginia itself, this map shows the case rates by county, and it shows that 45% of the counties have a case rate currently higher than 40 cases per 100,000, and only 2% have very, very high case rates of more than 100 cases per 100,000. The yellow represents higher cases, the blue are lower cases. And this week compared to last, we have seen some pretty substantial declines in the far southwest region. At the district level, we examine every week to see how many districts are in surge, and this week, very happily, no health districts are in surge, and this is actually pretty optimistic. 33 of the 35 health districts are in a declining scenario. Only 2 of them are showing slow growth, but overall, we would say that this is looking pretty optimistic. In examining the effective reproduction number, again, some very good news this week. The weekly change has shown a decline both statewide and in every one of the health districts, the health regions. Statewide, we're at 0.78, which is great, and at about 0.7 to 0.8 in all of the different regions. So we're continuing to go in the right direction here. Now, test positivity rate, which we had seen increase pretty dramatically, is continuing to decline. We are approaching about 10, so also going in the right direction, and the number of days from onset to diagnosis has decreased a little bit now. We're a little under 4 for January. So both of these, after having seen some slightly more pessimistic data recently, is looking more optimistic again. And this is the risk slide that we've been showing in the past. We're now past holiday travel, which was one of the greater risks that was posed in the November, December, slightly in January timeframe. So we seem to have moved past most of that. And right now, the biggest risk we're currently facing seems to be seasonality, although the variants are also now becoming a bigger concern. We're starting to get to the time of year where we think variants might have a bigger role. And the vaccine, of course, is also beginning to roll out, which might have some favorable impacts on what we see in terms of the rates. Okay, so these next slides are a summary of the various scenarios that UVA has been modeling, and I will just highlight some of the changes that have happened. I won't go through all of these slides in detail. They're generally the same as last week. The seasonal effects really haven't changed. Again, they look at both the best of the past, which is looking at the lowest level of transmission that we've seen in the past, and also at a fatigued control scenario, which is sort of a worst case scenario, looking at the highest level of transmission we've seen, plus an additional little 5% boost to see how things might happen if our public health behaviors either improve or get worse. And the next slide. They also look at the variants. This particular scenario had a couple of changes from the last week. They are now assuming a 40% increase in transmissibility from the variants, looking at variant B117. Last week it was 50%, so they've changed the transmissibility increase just a little bit, and are also projecting that the variants will become predominant in late March, whereas last week it was mid-March, so slightly later, and the increase in transmissibility is going to be a tiny bit less. And then the next slide is looking at vaccines, and here what I would say is noteworthy is looking at the figure on the bottom right. We can see there's just been a slight decline in the number of vaccines that are being administered per day. So that is the biggest impact that the vaccines have had on this scenario this week. And we can move on to the next slide. Actually, why don't we go to the next slide? We can go over to this one. So this just summarizes the 6 different scenarios that are being modeled. The adaptive scenario is looking at things as they currently are. Then we have changed the adaptive scenario both with the fatigued control and the best path to see sort of a worst case, best case scenario. And each of those 3 are then paired with the variant to see the impact that an increased transmission boost might have as a result of the variant. Next slide. All right, so this is looking at the adaptive scenario, and we can see that the path is in blue and what is being projected is in that gold color. So it does appear under the current course that we have passed the peak. The peak occurred towards the end of January at about 40,000 cases per day. And we're currently experiencing a decline, and under the adaptive scenario, it looks like the decline will continue. next slide. Okay. Oh, I may have missed one. So the can you go back one? Here we go. Okay. So sorry. The fatigued control scenario is then the scenario where we're maybe relaxing some public health precautions and going to experience an increase in transmission similar to the worst we have seen so far. So under this scenario, it looks like we will experience another blip in the spring, but it won't be quite as high as the highest peak that we saw earlier in January. In the next slide. This now shows the fatigued control scenario paired with the variant B117, which again is showing an increased transmission by about 40% beginning in late March. So if we do see something like this scenario projects, then we might expect to see another peak just as high as the one we saw in January, sometime in the May timeframe. This figure summarizes all 6 of the scenarios. We just highlighted 3 of them, but on this figure you can see all 6. There's a lot of overlap there, and both the current course and the fatigued control, and in fact all of the scenarios, have predicted that the peak occurred the week ending January 24th at a little over 40,000 cases. But the fatigue plus variant scenario shows we might have another peak again the week ending May 30th at just under 40,000 cases. Next slide. And then finally, we look at the hospital demand and capacity by region, and the UVA model is not predicting that we will reach or exceed hospital capacity in any of the regions in the near future. All right, and I think the last slide is just some contact information for websites, where to find the modeling results. So as always, we update the data insights page and various dashboards showing this information. And I am happy to take any questions in the chat.
Thank you, Chelsea. At this time, we'll have question and answers in the chat box. If you've joined the meeting by WebEx, please type any questions for presenters in the chat box. If you've joined the meeting by phone, please email your questions to donald.moore@vdh.virginia.gov with the subject line LHD call question. I'll leave the call open for about 10 or 15 minutes or so and see if we have any additional questions that come through, at which time we will end the call, and you can enjoy the rest of your day and long weekend. Thanks and have a great day.